Okay.
Right. Okay. So let's go on to nephrology then. So a few more days and we are done. And then it's up to you. All right. Right. So nephrology is a relatively easy topic. There are not a lot of things that you need to study in nephrology. So let's start with acute kidney injury. Now, when we are doing emergency medicine, I told you that acute kidney injury is mainly a diagnosis based on parameters and not clinical features. Right? So it is a diagnosis which is mainly made on parameters, right? And these parameters are the creatinine and the urine output, right? The parameters are the creatinine and the urine output. Now, it's important to remember patients with acute kidney injury can have symptoms and signs, but these are late. So by the time the patient manifests symptoms and signs, that is full-blown acute kidney injury, right? Full-blown acute kidney injury. So in order to identify acute kidney injury early, we use creatinine criteria and urine output criteria. Right? And this is called the KDIGO definition of AKI. Right. Now, the first MCQ focuses on causes of AKI. Again, this is something which is familiar to you. We classify AKI into pre-renal, intrinsic renal disorders, and post-renal disorders. So you have the pre-renal disorders, intrinsic renal disorders, that is the problem inside the kidney, and the post-renal or obstructive causes. So right? Now, of these three, pre-renal is quite common, right? Pre-renal is very common. You see it a lot, right? And as you can see, the pre-renal pathology of pre-renal AKI is due to renal hypoperfusion, right? Or impaired renal autoregulation. Autoregulation is a mechanism within the renal arteries that maintain blood flow to the kidney. So if you have impaired autoregulation or you have low perfusion to the kidneys, you can develop pre-renal AKI. Right? That is probably the most common cause of AKI that we see in clinical practice. Right? Okay. So true or false regarding acute kidney injury is most often due to pre-renal causes. And pre-renal causes are mainly where instances where the kidney perfusion goes down, the blood flow to the kidneys goes down. And also another possibility is there is abnormal autoregulation of renal blood flow. And abnormal autoregulation of renal blood flow is classically caused by NSAID-induced AKI, right? Because NSAIDs interfere with the prostaglandin production, which can interfere with renal autoregulation. Right? Another set of drugs that can cause problems with renal autoregulation are the ACE inhibitors and angiotensin receptor blockers. Right. Okay. Right. Now, from the renal, sort of intrinsic renal disorders, I would say that tubular disease, right? Tubular disease, especially acute tubular necrosis, is common as well, right? Now, remember, acute tubular necrosis and tubular disease can occur if you have prolonged pre-renal AKI, right? If it's untreated for a long time, then you can have acute tubular necrosis. Tubular disease can also occur with various other nephrotoxins like contrast, aminoglycoside, antibiotics, amphotericin B, and rhabdomyolysis. They're all toxins, nephrotoxins, and these can damage kidney tubules. So in the intrinsic renal category, I would say that this renal tubular damage or acute tubular necrosis is an important cause of AKI within that group. Now, a few things that you need to know about these nephrotoxins causing tubular disease. Contrast-induced AKI is seen in clinical practice. And the typical story is it occurs about 3 to 5 days after exposure to contrast. Right? So 3 to 5 days after exposure to contrast, not immediately after. Right? And we also talked about nephrotoxins like antibiotics, aminoglycosides. Amphotericin B is the famous tubular nephrotoxin. Tubular nephrotoxin, right? So those are all various causes of tubular dysfunction. Now, the last MCQ, AKI in tumor lysis syndrome is due to precipitation of uric acid within the renal tubules. Now, tumor lysis syndrome කියන්නේ මොකක්ද? So, tumor lysis syndrome is, say, when you have a cancer and you treat it with chemotherapy, all the cells start dying, right? You have a cancer and you're whacking the cancer with chemotherapy, the cells start dying. And these dying cells release metabolites and uric acid into the circulation, which can crystallize within the kidney tubules. And if you look at this figure, which is very important for MCQs, I would say, that you would see that within the sort of tubular nephrotoxins, I've also included this intratubular crystals, right? And a classical example of intratubular crystals would be uric acid crystals, when there is high cell turnover, right? Or high cell death. And one of those examples is tumor lysis syndrome. I'm just talking about causes here. So pre-renal, renal, post-renal is due to obstructive uropathy, right? And that is again a very important cause of AKI. Right. So further MCQs about pre-renal AKI. Pre-renal AKI can lead to acute tubular necrosis is true, as I told you, because pre-renal AKI is either there is impaired blood flow to the kidney or there is impaired renal autoregulation. Or you can have, if it's prolonged and you don't treat it quickly, it can cause tubular ischemia. The blood flow to the kidneys is low, Nisa. It can cause tubular ischemia and tubular necrosis. Right? That is important. Now, pre-renal AKI has certain biochemical hallmarks, right? And you can work this out. Now, when, say you have pre-renal AKI, where there is reduced blood flow to the kidneys, right? What does the kidney try to do now? It tries its best, because there's low blood flow, the kidney tries best to preserve salt and water. It tries to preserve salt and water, making the urine more concentrate, right? It preserves salt and water, making the urine more concentrate. So there will be a higher urine specific gravity and a higher urine osmolarity if you have pre-renal AKI, because the kidney is trying to retain the salt and water. So it's making the urine concentrate by taking all the salt and water back into the body. So the urine will have higher specific gravity and there will be higher osmolarity level, right? But if you actually measure the excretion of sodium, right, because sodium is all being reabsorbed, the urinary sodium concentration will go down, right? Because sodium is all being reabsorbed and the urinary sodium concentration is low, right? So the urine will be more concentrate, less water in it, high osmolarity, high urine specific gravity. Actually, if you measure the sodium concentration, that will be low because the sodium is being reabsorbed as well. So this is how you would diagnose pre-renal AKI using these investigations like urine sodium, urine specific gravity, and urine osmolarity. And also remember, another very important thing is in pre-renal AKI, you have a disproportionate rise in the blood urea versus the creatinine. Because actually urea is a good marker of dehydration and volume depletion. So the blood urea will be higher in proportion to the rise in the serum creatinine. So you can actually measure something called the, you can actually measure the urea in the blood or in the urine. But essentially there is a disproportionate rise in the urea. Right? There will be a disproportionate rise in the urea. And you can measure that with the plasma urinary nitrogen creatinine ratio. Now make a MCQ වලට ටිකක් famous area එකක්. What are the biochemical features of pre-renal AKI කියන එක? So knowing that the urine is more concentrate, high specific gravity, but lower urinary sodium, right? And the excretion of sodium is reduced because the body is trying to retain the sodium. And also the urea in the plasma will be higher because it is a state of hypovolemia, a state of dehydration. Remember, MCQ in actual clinical practice, it is very rarely that you do all of these sort of investigations. You can make a clinical judgment, right? What the cause of the AKI is. But for MCQ, this is a important area. So prerenal AKI, first MCQ එක හරි, second MCQ I told you, sodium is being conserved. So the sodium excretion is reduced, something called the fractional sodium excretion. And urine osmolality, specific gravity are increased and cause a disproportionate elevation of urea in compared to serum creatinine. So the statement 2, 3 and 5 are all false. Sorry, 2, 4 and 5 all false. It should be the other way around. And in prerenal AKI, if you examine the urine, it is a bland sediment. Mukut nahe, right? There is nothing in the urine. Maybe a few hyaline casts. Right. So that is another MCQ about, so that the biochemical manifestation, investigation profile of a patient with prerenal AKI. Right. Now, this also sometimes is asked for MCQ, so I put it on your slide. In the various causes of AKI, pre-renal, renal, post-renal, the urine analysis may reveal certain features. In glomerulonephritis, as you know, they get what you call an active sediment with hematuria, right? Proteinuria and granular casts. Another important intrarenal cause of AKI is interstitial nephritis. In interstitial nephritis, this can be caused by drugs, right? Interstitial nephritis, antibiotics are a famous cause of interstitial nephritis. And these people get leukocytes in their urinary sediment. Right? Leukocytes in the urinary sediment. And also eosinophils, urine eosinophils. That is a slightly unusual thing, but something that you can get at as MCQ in interstitial nephritis. Okay. Any questions up to now, Lamai? It's very close to exam. I'm sure that you are very good at this now, but I'm just going through it so that we are absolutely sure that you pass medicine with flying colors. And you can concentrate on the other subjects after that. Okay, so true or false regarding AKI, right? I told you right at the start that it is very difficult to diagnose AKI clinically, and you use investigation findings to diagnose it. In AKI, the kidney sizes are usually normal or slightly bigger, right? It is in CKD that the kidneys are small. Again, we remember this. Now, AKI can be associated with multi-organ dysfunction, right? Multi-organ dysfunction. So they can get bleeding as a result of that, right? Multi-organ dysfunction. And also, when you have AKI, the uremia causes problems in platelet function and clotting factors. So all of these contribute to an increased risk of bleeding. Right. Now, some people follow a classical natural history of phase presentation of AKI. The classical phases of AKI, like the oliguric phase, polyuric phase, in your modules. This is typically seen in patients with acute tubular necrosis, right? The oliguric phase and the polyuric phase. Right? Now, the oliguric phase is essentially the height of the problem, right? The polyuric phase happens during recovery, right? Polyuric phase happens during recovery, right? Where the necrosed tubules start sort of regenerating, but the brand new tubules are not as good at reabsorbing salt and water. So they get polyuria because the patients cannot reabsorb salt and water through those brand new tubules. Right? So just remember the phases of AKI, oliguric, polyuric phases are typically seen in patients with acute tubular necrosis. And the polyuric phase is where you have tubular regeneration. But these new tubules cannot reabsorb salt and water as well as the existing ones. It takes time for them to mature. Sorry. So that is important. Now, management of AKI is medical. You can correct the underlying cause, right? So if it's, for example, if it's pre-renal, you give fluids. If it's an obstruction, you relieve the obstruction. We talked about this in the emergency medicine classes, right? And of course, managing all the complications. And there was this old thing where you gave dopamine that doesn't work. It's nonsense. There is no survival benefit. Right. And diuretics are just used as a simple measure to relieve symptoms, right? And you don't give diuretics to everybody with AKI, and they can be harmful if you use it in the wrong person. It can worsen the AKI sometimes. Imagine if you give diuretics to a patient with pre-renal AKI, the patient's AKI will get worse. Diuretics are used specifically if they have a lot of fluid overload, pulmonary edema, to try to relieve the pulmonary edema. But you have to be very, very careful, underline the word, very, very careful when you're using diuretics in AKI, because you can make it worse, right, if you're not careful. Right. Okay, right. Any questions about AKI? So again, I have taught you all of these management of hyperkalemia during your acute medicine classes. Because you already know that. Right, now we're transitioning now from AKI into CKD, and a common MCQ that we find is, what are the differences between AKI and CKD? Actually, the main differentiating features between AKI and CKD is mostly the renal sizes, most of the time. So I taught you this when we were doing the long case classes as well. CKD, most of them have small shrunken kidneys, most of them, right? There are 3 exceptions to this rule. So diabetic nephropathy, HIV nephropathy, and amyloidosis can cause chronic kidney disease with normal sized kidneys. Diabetes, amyloidosis, and HIV associated nephropathy. They can progress to chronic kidney disease, but the patient will have normal kidneys or slightly enlarged in some cases. Right? So exception. Apart from those, almost all other causes of CKD, the kidneys will be small and shrunken. Right? This is very important. Now, the other abnormalities like anemia, renal bone disease, are common in CKD, but you might actually see some of them even in prolonged AKI patients. Right? If the AKI lasts for several weeks, you might see these certain erythropoietin deficiency anemia, right? The renal bone disease start to set in. So it's not a very good feature. It is common in CKD, but it's not an absolute feature to differentiate. Right? Okay. The most important, one of the most important parameters would be the ultrasound scan. Right? And in most cases of CKD, the ultrasound scan will show small shrunken kidneys. The rest of it is difficult to interpret. Renal bone disease, calcium phosphate abnormalities, anemias can occur in both, but commoner in CKD. Right. Any questions up to now? So this ultrasound shows, as you can see, a small shrunken kidney in CKD in the first picture. Whereas in a AKI, the patient's kidneys are usually normal or maybe slightly swollen. Any questions, Lemai? Now, CKD can be sometimes difficult to diagnose, but usually as the rule of thumb, rule of thumb it's a කාරණයක්. So if you have prolonged impairment of renal functions persistently for 3 months or more, they are very likely to have CKD. Right? So if your renal functions are abnormal, sustained for 3 months or more, they are likely to have CKD. And CKD is classified using two classifications. One is based on the GFR, as you can see in the figure, right? And the other one is proteinuria. So it gives you a glomerular filtration rate stage plus a proteinuria stage. That's how you classify CKD. And overall in the world, diabetic nephropathy is the commonest cause of CKD, by obviously. Right? Okay. Right? But remember, there is a GFR based stage and a proteinuria based stage. CKD can be thought of, or is very likely, if your renal functions are prolonged, there is prolonged abnormality of renal functions beyond 3 months or so. Right. Now, in your long case, we talked in detail about complications of CKD. And remember, we talked about anemia, renal anemia. Now, renal anemia becomes evident only when the GFR declines below 15. You can see actually renal disease anywhere below 45, 50, 45, a range you get renal anemia. I would say 60, 45. That is the range where it starts usually. Right? So that is less than 15 is in stage or the last stage, but the anemia starts a bit earlier than that. Right. Now, all of you should know that the anemia that occurs in CKD is mostly normocytic normochromic. Right? Normocytic normochromic. Now, so here I have mentioned anything less than 60, right, is where you would get this classical renal anemia. Hari. Now, I told you this as well in the long case classes. There are lots of causes contributing to anemia in CKD. And this can be asked even in a SCQ or even the long case. I told you that CKD is a chronic inflammatory state, and this causes anemia of chronic disease, right? Anemia of chronic disease. Also remember, in CKD, there is obviously decreased erythropoietin production because erythropoietin is produced in the kidneys, right, in adults. So there is reduced erythropoietin production, right? So there is anemia of chronic disease due to the background chronic inflammatory state, and there is reduced erythropoietin production. But I also told you very importantly that there are lots of dietary deficiencies in patients with CKD, and this contributes to the anemia. Dietary deficiencies in iron, dietary deficiencies in B12, folate, all contribute to anemia in CKD, right? And on top of all of this, these patients have increased bleeding, right? Short red cell span, right? And there are problems in their bone marrow also, bone marrow suppression in the pulluwan. And also there is a lot of bone disease which also affects the marrow and the bone structure, right? So all of these can contribute to anemia of CKD. And unusually, ACE inhibitors can also cause anemia. There is a complicated mechanism which you don't need to worry about because your exam is only 2 weeks away. But if somebody asks you, ACE inhibitors can also contribute to anemia in CKD. Okay? Right. Okay? If you're really interested, this angiotensin 2 can stimulate erythropoietin production. Right? That's why when you block the ACE mechanism, erythropoietin production can also be affected. Right? So ACE inhibitors, through the reduction of angiotensin 2, can reduce erythropoietin production. Angiotensin 2 increases erythropoietin production. Right. So again, this is all good area for MCQ. Even in SCQ, we might ask you write short notes on anemia and chronic kidney disease. So you have to start by saying, when does it appear? What are the causes? So, and remember, I taught you that when you are managing anemia in CKD, it's very important to correct underlying iron deficiency before starting the patient on erythropoietin, right? And that is how you treat them. And obviously you do iron studies, and the cutoffs are different. I taught you this in the long case, right? So transferrin saturation less than 30 and ferritin less than 200 would be iron deficiency. Yeah, just ignore this. That's in Sri Lanka, we use the iron studies still to diagnose, but in other parts of the world, people use other things like blood film appearance, right? So if, for example, you can measure the percentage of hypochromic cells, right? That is a test which is used sometimes. Sorry, it's transferrin 20 and ferritin less than 100. Sorry. This is latest guidelines, okay? ඒ දවස්වල 230 ක දැන් ඊට වැඩි පොඩ්ඩක් වෙනස් කරලා. So medicine is very difficult because it changes every day. Okay. So it's very important to correct underlying iron deficiency, otherwise වැඩක් නැහැ, නේ? There is no point in giving erythropoietin because without iron the bone marrow cannot produce any red cells. So yes, give the iron, and we talked about IV iron having a good place in patients with chronic kidney disease. Because CKD patients don't absorb iron very well through the gut. So better IV. And then obviously erythropoietin. Another thing I told you is that don't go too high on the hemoglobin. Right? 10 is reasonable. 12 is maximum. The usual range that we like to keep the hemoglobin is between 10, 11, A range. Right. So don't go for 14, 16, normal karanne yanne epa. Right? Because people have found that when you increase the hemoglobin too much, there is a increase in mortality. So you have a nice sweet spot of hemoglobin that you're trying to achieve. 10 to 12, 10, 11 wage thamai honda. And I told you that blood transfusions are not preferred. Try to avoid them, especially if the patient is going for transplant. Try to avoid blood transfusions. Right. Any questions? Any questions, Lamai?
සර් ඒකයි CKD differentiate කරගන්න factors වලදී අපි අනිත් ඒවාට true false ගහන්න නැතුව ඉන්නවද මේ renal size එක විතරක් mark කරලා
මෙහෙමයි දැන් ඒක මෙහෙමයි මම අතන මේ ප්‍රශ්නේ මම දීලා තියෙන statement එකේ පොඩි දුර්වලතාවයක් ගොඩක් වෙලාවට ඔක අහන්නේ what are the following are more suggestive වගේ නිකන් නේ එතකොට ඒවා true ගහන්න පුළුවන් ඒක CKD more suggestive of CKD than AKI කියලා අහුවොත් එහෙම එතකොට ඔය bone problems අනීමියා ඒවා ගහන්න පුළුවන්. එහෙම තමයි සාමාන්‍යයෙන් අහන්නේ. හරි මගේ මේ ස්ටේට්මන්ට් එක වර්ඩ් කරලා තියෙන එච්චර හරි නෑ. එමෙ ambiguous දේවල් අහන්නේ නෑ පැහැදිලිව අහයි. Question 5. Oh sorry. So anemia and CKD can be, in some people we find that there is a certain degree of reversibility when you dialyze them, not completely. Certain degree of improve when you dialyze them, and partly that is because when you remove the uremic toxins, it improves the bone marrow function and things like that. Right? It also reduces a bit of inflammation. Okay. Right. Now again, question 6 is another complication based on another complication of CKD, and we talked about this in detail during the long case discussions as well. Renal bone disease. So Manka, renal bone disease, there are types, various types of renal bone disease. Renal osteodystrophy is the more common variety, which is driven by hyperparathyroidism. Renal osteodystrophy is a hyperparathyroid related mechanism. Osteomalacia is due to vitamin D deficiency because, as you know, vitamin D is activated in the kidneys. And I also told you about adynamic bone disease in the long case. Adynamic bone disease So we give medication to suppress the PTH, right? Like calcium carbonate, වගේ දේවල්, right? Vitamin D, we give that to suppress the PTH levels. If you oversuppress the PTH levels, also this can be a problem. Like if you oversuppress it, because a little bit of PTH is necessary for healthy bone formation and healthy bone turnover. So you should not oversuppress the PTH. And ideally, you should be monitoring the PTH levels when you're giving calcium carbonate and vitamin D. Right. True or false regarding renal bone disease? Gut absorption of calcium is increased when the main stuff that absorbs calcium from the gut is vitamin D. So because vitamin D is not activated, the gut calcium absorption is reduced. And that is partly why they become hypocalcemic initially. And they have hyperphosphatemia. Why do they have hyperphosphatemia? Because phosphate is actively secreted in the kidneys, right, into the urine. So in kidney disease, the phosphate levels go up. And this combination of low calcium, high phosphate is what triggers the parathyroid hormone. This is what triggers so low calcium, high phosphate is the one that triggers the hyperparathyroidism. And vitamin D is one of the key things that absorbs calcium from the gut. So the absence of vitamin D, the calcium goes down. The abnormal excretion of phosphate, phosphate goes up. So that is what triggers the PTH mechanism. Hypercalcemia does not occur. I will tell you the reason for that. In renal bone disease, I told you they have low calcium, high phosphate, and there is parathyroid hormone release. Sometimes there can be excessive, unregulated parathyroid hormone increase, which is called tertiary hyperparathyroidism. So this is unregulated, excessive parathyroid hormone release, right? And that causes tertiary hyperparathyroidism. Okay, and that can cause hypercalcemia. That can cause hypercalcemia. Okay, so that is true. Alkaline phosphate is elevated in when there is bone resorption. The alkaline phosphatase goes up. Because alkaline phosphate is a marker of bone turnover. And the last statement again, we do not suppress the PTH to physiological levels, right? It's usually maintained between a certain range, but you don't drop it to physiological levels, right? Usually it's 3 to 8 times upper limit of normal. We maintain it at that level. Because oversuppression of the PTH can be more harmful, can lead to adynamic bone disease. Okay, right. Now, I told you that it's not only renal osteodystrophy and adynamic bone disease that you get, you also get other things like osteomalacia, right? Here you can see this rugged jersey spine appearance. Another thing that you get in osteomalacia is this sort of small fractures or looser zones, microfractures like things. Okay. Right. So that's about renal bone disease. Now also, renal bone disease osteoporosis can also occur in patients with chronic kidney disease. Right. Now this question 7 is just a list of things that can happen in patients with CKD, metabolic changes. And in the next slide, I have given you all the things you need to know for MCQs. So hyponatremia is very common because of dilution, because of fluid overload. They also have various thyroid hormone abnormalities. Hypothyroidism is common. Or we talked about sick euthyroid state. That is another thing that can occur. They have deranged lipid profiles. A lot of menstrual abnormalities, hyperprolactinemia, and also sex hormone deficiencies as well. Okay. Now, question 8 is again focused on the management of CKD. Now, I'll talk about that again, remind you what we did in the long case. When you're managing CKD, right, early stage CKD, late stage CKD, the management is different. Right. In early stage CKD, your most important priority is to limit the progression of renal damage. So there, the main things we do, maintain the blood pressure and also give drugs to reduce proteinuria. And that is very clear. There are many, many studies out there that show that when you reduce proteinuria, the progression slows down. Right? Progression slows down. So ACE inhibitors are not contraindicated in CKD. You have to be careful when you're using them in end stage. But in the early stage, this is one of the drugs that we give them. The main idea is, number one, for blood pressure control. Number two, for proteinuria control. Right? So that is very clear that proteinuria control improves renal outcomes. It sort of reduces the progression of the renal problem. All right. Now we talked about the hemoglobin target. Erythropoietin therapy wala side effects, pure red cell aplasia is a rare side effect. The other common side effects are hypertension and polycythemia. Right. Okay. And then we talked about adynamic bone disease, right? So you oversuppress the PTH, you get adynamic bone disease. Now, sevellema kiyaneka echarama danagannu onne hai. It is a type of phosphate binder, which is used in bone disease, right? Phosphate binder. මේ MCQ ecchara වැදගත් නෑ. ටිකක් එක ඕනට වැඩි. So then I think we have, yes, talked about chronic kidney disease then. Okay. And then especially focusing on anemia, CKD related bone disease, various types of bone disease. And we've talked about the management. Api long case ke mewa detail kara, ma MCQ tikiya ma matak karagana iyame, right? Right. Purna Adisha halatino, sir, CKD patient. So most of them do have proteinuria, but not all of them progress into end-stage renal failure. Right? Not all of the patients that present with CKD, they don't go into end-stage renal failure. Right? Right. Any other questions? Okay. Now going on to glomerular disease. Again, long case එකක් අපි කරලා තියෙනවා glomerular disease ගැන, just to remind you. Now, glomerular disease has a spectrum of manifestations. Right? There's a spectrum of manifestations. Right? On one end of the spectrum is nephrotic syndrome. Right? On one end of the spectrum is nephrotic syndrome. Another end of the spectrum is nephritic syndrome. Right? And these figures nicely show all of this. Right? Figures. So on one end of the spectrum, they have glomerular disease. It's a spectrum of presentation. On one end of the spectrum, they have nephrotic syndrome. On another end of the spectrum, they have nephritic syndrome. Nephrotic syndrome, as you know, has proteinuria, hypoalbuminemia, edema, and hypercholesterolemia. And they might have this intravascular volume depletion. Nephritic syndrome, on the other hand, they have hematuria, little bit of edema, hypertension, and oliguria. Right? These patients present. Okay, so that is a sort of two ends of the spectrum, nephrotic, nephritic. Right. Take all done. Fine. So make a lay ඕන කෙනෙකුට උත්තර දෙන්න පුළුවන් දෙයක්. Right. So nephritic syndrome, right? New onset hypertension, they get fluid overload oliguria, serum albumin hyperlipidemia doesn't occur. They have inflammation, so their ESR will be high. Right? So this is an easy one. So recognize the spectrum of manifestations of glomerular disease. Nephrotic, nephritic. Right. Now, this next MCQ is again something frequently encountered in papers, if you have seen done papers. මේක ඉතින් අර මෙමනේ අපි examination එකේ හරි කම්මැලිනේ බා. කම්මැලි නිසා ඔන්න ඔයගේ list එකක් දීලා ඉතින් එක MCQ එකක් හදා ගන්නවා. I'm very much against that because this sort of thing කටපාඩම්නේ බා. වැඩක් නැහැ ඉතින් ඕක. Right? So you should know some of the causes of nephrotic syndrome, some of the causes of nephritic syndrome, and I've given you a big list of causes in this slide. Remember, some causes, some are idiopathic, right? And some there is a secondary cause. Right. Now, glomerular disease can also be classified based on the histopathological type. Right? The histopathological type. Right? And you have various types of histopathologies that you get in glomerular disease. Right? Of these, pathologies like minimal change disease, FSGS, and membranous nephropathy. Right? So, minimal change disease, FSGS, which is focal segmental glomerular sclerosis, and membranous nephropathy, they present with nephrotic syndrome. People who have more inflammatory proliferative types glomerulonephritis, so more proliferative inflammatory glomerulonephritis, they present with nephritic syndrome. They present with nephritic syndrome. So that's an easy way of understanding this very complicated area. Right? So at the top, you have the clinical classification, which has a spectrum. On one end of the spectrum is nephrotic, the other end of the spectrum is nephritic. Causes can be idiopathic or secondary. And the third way of classifying is based on their histopathological appearance. On one end of the spectrum, you have the minimal change, FSGS, and focal segmental membranous nephropathy, which present with nephrotic syndrome. And on the other end, you have the inflammatory proliferative glomerulonephritis like post-streptococcal glomerulonephritis, some SLE-related glomerulonephritis that presents the nephritic syndrome. Of course, you can have a mix of the two as well. But this is how you sort of understand the classification. I'm not sure whether Dr. Landrol did the lectures on glomerular disease. Peter Karnakaran, he used to come, no slides at all. I don't know whether he still teaches you this. No slides at all. මේ හරි එක ස්ලයිඩ් එකක් වගේ තමයි තියෙන්නේ. ඒක දාලා බෝඩ් එකේ ඇඳලා ওই වගේ විනාඩි 15 විතර he teaches this. හරි. I don't know whether you had the pleasure of listening to his lectures on glomerulonephritis. හරි. It just comes and one slide board එකේ ඇඳලා කතන්දර ඉවරයි. And I can still remember, so there was a pathology lecture before Landrol came, and the slide ticket තිබුණා ඒක බලලා මේවා complicated වැඩි. He did a pathology lecture also then. I used the cunning lecture slide ටික දාලා ගිහලා Landrol සලා pathology lecture එකක් කරලා ඊට පස්සේ එයාගේ lecture එකක් කරලා ගියේ. Okay, so yeah, interesting, right? So whatever. So fine. Now let's talk about minimal change. Is the commonest cause of nephrotic syndrome in adults is false, right? The commonest cause of nephrotic syndrome histopathological wise is membranous nephropathy. Children, yes, minimal change. Minimal change can have a familial association. There is a type of minimal changes in pediatrics also you'll be taught this called congenital nephrotic syndrome, congenital sort of minimal change disease. Now, the histopathology of minimal change disease can be associated with other pathologies, secondary causes like Hodgkin's lymphoma. It's a famous cause of minimal change pattern on the histopathology. And it's called minimal change because you don't see anything much on microscopy. You might see some lipid deposition in the tubules, which is the fourth MCQ is true. But in electron microscopy, you will see these sort of podocyte food process abnormalities. Slide එකක් ඇති මෙතින්. So මේ slide එකේ ඔය විස්තර ටික ඔක්කොම තියෙනවා. Okay, this is exam එකට යන්න කලින් පොඩ්ඩක් බලාගෙන යන්න ඕන table එකක් මේක MCQ ගණනාවක් තියෙනවා points ගණනාවක්. Right. Okay. Right. Does not progress to CKD, that's false. Actually, the highest risk of progressing to CKD is FSDS. Minimal change can also rarely progress to CKD. But the highest risk is with FSDS, focal segmental glomerulosclerosis. Right. There's another MCQ, I think, on FSDS now. Sorry, minimal change. Now, minimal change, you would have had lectures on this in pediatrics, very common in children, right? And characterized by almost near normal light microscopy appearance. You might see a bit of lipid droplets we discussed in the previous MCQ. The classical feature of minimal change causes highly selective proteinuria. So it's just the albumin that goes out, nothing else, or maybe other few proteins that go out, right? Complement levels are normal. And from your pediatric lectures and appointments, you would have noticed that relapses are quite common in patients with minimal change. This is extremely uncommon. And children respond much better to treatment when they relapse, and they respond much better to steroids than adults, right? So as you know, in minimal change disease, the treatment is steroids, right? That is a primary treatment. Children respond much better than adults with minimal change disease to steroids. That is an important thing to remember. So in adults, we use various other medications like cyclosporine, for example. Cyclophosphamide is another one that we use. So minimal change disease is common in children, very selective proteinuria, and children respond much better to steroids compared to adults. Adults, we need other medication like cyclosporine, cyclophosphamide. Right, so this table gives you sort of important aspects of things that you might need. But MCQ, what are the causes of focal segmental glomerular, secondary cause of focal segmental glomerular, cause of membranous nephropathy, right? So membranous nephropathy is particularly famous because it is associated with malignancies. That's a very important thing that you need to remember. MCQ histopathology වැඩි අහන්නේ නැහැ. And you should know that minimal change responds to steroids very well. Okay. Whereas membranous doesn't respond at all generally to steroids. Now, on the other end of the spectrum, we have nephritic syndrome. Right. Right. Now, in nephritic syndrome, so post-streptococcal glomerulonephritis is one of the commonest causes of nephritic syndrome. And it is due to group A beta hemolytic streptococci. Now here in post-streptococcal glomerulonephritis, right, they have a lot of inflammation and proliferation in their kidneys. Inflammation, proliferation. Now you already know that they will have red cell casts and a bit of proteinuria. And they have low C3 levels, but normal C4. MCQ at 100. Don't ask me why. They have low C3 levels, but normal C4. And because this is a proliferative inflammatory condition, if you look at the kidneys in histology, you will see a lot of immune cell infiltrates and a lot of proliferation, hypercellularity, right? Hypercellularity. And also you get a lot of immune depositions within the kidney, right? And crescent formation can also be seen sometimes. Mahesh, cyclophosphamide hydration protocol differs on the unit. So, right. So, low complement levels are associated, their C3 levels are low. in the kidney histology, crescent formation, hypercellularity, and there is a lot of immune deposition in the subendothelial spaces, right, just below the endothelium. Lots of immune sort of stuff depositing there, right? That is a typical appearance you see, right? And they require nothing, just observation, right? They don't need any immunosuppression. Most of the time, they spontaneously resolve. Most of the time, these are this is a self-limiting disorder. Most of the time, it's very, very rarely that you would give immunosuppression to people with post-streptococcal glomerulonephritis. Okay, right. Any questions about glomerulonephritis? So glomerulonephritis can appear even in a long case when you have a patient with edema, something with nephrotic syndrome. The discussion would obviously go along the lines, and we've discussed, I think for all groups, I have done very similar classes so that it limits the variation of the teaching. So for all groups, I have done a patient with edema and glomerular sort of nephrotic syndrome. So we have gone through this in detail before. Right. So the question 14 is on polycystic kidney disease. And this is how it looks like on the ultrasound scan. Now, polycystic disease, මෙන්න මේ MCQ points ටික මතක තියාගන්න. මේක නිතරම අහනවා වෙනම MCQ එකක් විදියට about polycystic kidney disease. Now, as you know, there are two types of polycystic kidney disease. What is more important for us is the type 1, adult onset one, which is chromosome 60. Now, it's very important to recognize that these patients are asymptomatic till about their 40s, 50s, 60s, right? And CKD occurs usually around 60s with her, right? Okay. The most important thing they ask for MCQs is, or we ask for MCQs, is that there are extra-renal manifestations of polycystic kidney disease. List එකක් මේකේ තියෙනවා. Already we have discussed, I think, at some point that it causes increased incidence of berry aneurysms in the circle of Willis. Okay. So, පළවෙනි එක හරි. Second decade of life එක බයිලා කතාවක්, usually CKD 60s, 50s, 60s. Is associated with hepatic cysts, yes. Is associated with intracerebral aneurysm formation, that is also true. Now, how do you manage polycystic and autosomal dominant? The common form is autosomal dominant. Polycythemia ගැනත් අහලා තියෙනවා. In PCKD, you get polycythemia also because these cysts can, unusually enough, they can secrete erythropoietin, some of the cysts. And this is one of the types of CKD where anemia is not very common, right? Polycystic kidney වල වැඩි anemia ඉන්නේ, right? That's a complication of CKD. Management is supportive. People believe that renin-angiotensin-aldosterone system blockade helps, and also there are now drugs that block the sort of vasopressin system that are supposed to be beneficial. When there is a cyst infection, which is a common complication of polycystic, remember that we have to give them antibiotics, and coamoxiclav does not work. That is important to remember. අපි UTI වලට ඔහේ coamoxiclav දෙනවා, polycystic වලට බෑ. ඒක මතක තියාගන්න. We usually use cotrimoxazole or things like ciprofloxacin. The reason for that is, in a cyst infection, coamoxiclav does not penetrate into the cyst. That is the reason. So use other antibiotics. This is a very famous MCQ point, cotrimoxazole and cipro. Okay, right. So that is it. Any questions before we go on to the best response ones? So question 1 is easy. Hematuria, nephritic syndrome වගේ කතාවක් තියෙන්නේ, red cell casts එහෙම තියෙනවා. Sore throat 2 weeks back. this is very nicely fitting in with the diagnosis of post-streptococcal glomerulonephritis. Now remember, IgA nephropathy කියලා එකක් තියෙනවා that can present in a very similar way to post-streptococcal glomerulonephritis. The only difference usually is that the sore throat and the hematuria and the nephritic syndrome come together in IgA nephropathy. In post-streptococcal, you have the sore throat before, and then about 2 weeks after, you get the hematuria and the nephritic syndrome. Right? So please remember that. IgA nephropathy, IgA deposit in our kidney, it's a rare disorder, but can be very similar in presentation to post-streptococcal glomerulonephritis. The main difference is IgA nephropathy, they have the sore throat and the glomerulonephritis at the same time. So here we have a 62-year-old woman, nausea, lethargy, and diclofenac amoxicillin, පාවිච්චි කරනවා කියලා තියෙනවා. Right? පාවිච්චි කරනවා කියලා තියෙනවා. ශාරක sorry, C4 normal වෙන්න ඕනේ. මට ඒක වැරදිලා type වෙලා තියෙනවා. C4 normal වෙන්න ඕනේ. C3 C4 දෙකම අඩු වෙලා nephritic syndrome එකක් આવොත් SLE තමයි possibility එක. But here I typed it wrong. C3 low, C4 normal. Right. So here we have amoxicillin, right? And there is a AKI, as you can see, and there is eosinophilia and proteinuria, white cells. මොකද්ද මේ මම මේක කිව්වා මුලින් නේද? මතකයිද බලන්න? So AKI with eosinophils in urine as well as in blood, and proteinuria with leukocytes is tubulointerstitial nephritis. Acute tubulointerstitial nephritis due to amoxicillin, most likely. Right? So that antibiotics are what cause tubulointerstitial nephritis. So this is acute. And the classical thing is eosinophilia, urine as well as blood, and white cells in the urine, leukocytes in the urine. Concept. Okay. Clinic referral, microscopic hematuria, blah, blah, blah. Yeah, so brother has hematuria, father SCH, මොකාටද මේ එන්නේ? Polycystic kidney disease, නේද? Polycystic kidney disease. So they can have bleeding into the cysts. And the fact that there is a family history of renal failure, father had SCH, might be a berry aneurysm secondary to polycystic kidney. So the answer here is a polycystic kidney disease, and an ultrasound abdomen is good enough to diagnose polycystic. You don't need to do CT scans. Ultrasound is a gold standard. Right. Question number 4. Patient with chronic renal failure comes to surgery can make a UK exam GP ළඟට එනවා කියන එක තමයි කියන්නේ. Tiredness, lethargy. So hemoglobin low, right? And there is low ferritin, as you can see, right? So I told you less than 100 now. Iron deficiency මතකයි. Creatinine. So there is some renal CKD, anemia with low ferritin. Fecal occult blood negative, which helps you to say that it's probably not gastrointestinal bleed, but there is clear evidence of iron deficiency in this patient. Ferritin transferrin saturation side, ferritin C වැඩි අඩු නම්, that is iron deficiency anemia. On top of the CKD anemia that you have. So here, IV iron is the treatment. Endoscopic occult blood කතාවක් දීලා තියෙන එකයි. So IV iron is the answer here. Before you give erythropoietin. So I told the oral IV is better because it is the bioavailability of IV iron is much better. Patients with CKD cannot absorb the oral iron very well. So that is a problem. Okay. So here cardiogenic shock, acute myocardial infarction, and then the urine output drops and the patient develops an AKI. Nothing much there. Okay. Nothing much there. Highline cast. And then the patient develops polyuria and the things improve. So patient has a oliguria, polyuria. මං කිව්වා මේක මොකේද ගොඩක් වෙලාවට එන්නේ? You get the classical oliguric phase when the tubules are necrosed and dying, and when the tubules regenerate, they get the new tubules, brand new tubules, are not as good as reabsorbing salt and water as the old ones. So they get polyuria. So in this patient, if you cut the kidneys open, they will have evidence of patchy tubular necrosis. Patchy, it's improving also in either. So there is patchy tubular necrosis. Part of it is regenerating, part of it is still necrosis. So what has happened is the patient had cardiogenic shock, prolonged prerenal AKI, which led to acute tubular necrosis that caused the oliguric phase, and then now the tubules are regenerating and going into a polyuric phase. So patchy tubular necrosis is what you get. So here we have a diabetes related question. Metformin denava, araka meka denava. Okay. So here, metformin should be stopped, right? Because I told you GFR less than 30 and creatinine more than 133 is the cutoff. So you should stop the metformin. So this is just a MCQ that looks at management of hyperkalemia. Right? So මෙතන පොඩි ප්‍රශ්නයක් තියෙනවා අතන මම ECG එක ගැන මොකුත් කියලා නැහැ. ECG එක ගැන මොකුත් කියලා නැහැ. මේ වගේ ECG එකක් දැක්කොත් මොකද වෙන්නේ? Yeah. මේ වගේ ECG එකක් දැක්කොත් obviously you start off by giving calcium gluconate, right? Calcium gluconate intravenous. You have to lower this potassium. මේ පොඩි දුර්වලතාවයක් මේක. මෙතන ECG changes තියෙනවා කියලා තිබ්බොත් the answer is IV calcium gluconate. ඒක දෙන්න ඕනේ නැත්තම් බෑ. And then also you give the insulin dextrose and nebulized salbutamol, and also you can give the oral potassium binders. මේ ටික තමයි සාමාන්‍යයෙන් කරන්නේ. ඔයාලා දන්න දෙයක්ම තමයි ඒක. That is it. Sajit, yes Sajit. So PCK diagnosis is ultrasound KUB, but ultrasound abdomen කියොත් නික ලොකු ප්‍රශ්නයක් නැහැ. හරි. ඒකේ KUB එකක් එක්ක තමයි කිය කරන්නේ ගොඩක් වෙලාවට වගේ. ප්‍රස්තාව. හරි. Right, so that is nephrology. So how tall should the tall T waves be? That's a good question. So if it's more than, if it's more than half of the QRS, the R wave, that is tall, right? So if it's more than half of the R wave, height, more than half of the height of the R wave, that is tall. So bicarbonate, you do give in hyperkalemia, that helps sometimes, but that's always with senior opinion. As a house officer, you can give the calcium gluconate immediately if there are ECG changes, and then the insulin dextrose. Salbutamol nebulization is not a very effective thing, right? Right. Renal papillary necrosis කියන්නේ අර renal papillae කියලා තියෙන්නේ අර tubules ටික set වෙන තැන ඒවා necrose වෙනවා. That you see in things like diabetes, sometimes NSAID induced AKI වල you get this renal papillary necrosis. Another thing is endocarditis also, you can get renal papillary necrosis. So fluid management in CKD is difficult. If they are passing urine, we usually ask them to drink about 1 to 1.5 liters a day. But if they are not passing urine, it should be less than 500 a day, right? Some people give the urine output plus maintenance fluid, but usually it's about say 500 to 1.5 depending on the patient. Strict guideline how much fluid to give care. Right. Any other questions? Sarangani.
Yes, sir.
So ඊගාට මොකද කරන්නේ අපි? Rheumatology.
Okay, sir. Sir,
We have
and
rheumatology. Yes.
so we have the best response questions from the endocrinology also.
ඒක අපි හෙට කරමුද?
Okay, sir. Sure. No.
මේ yeah, we do it tomorrow. මම ඇත්තටම ඊයර night එකක් කරලා මේ ඉන්නේ. because I didn't want to miss the class. මේ
No,
ඒකයි.
sir. We'll do
හරි.
it. Yes. Sir.
හරි, we do it tomorrow. Right.
Thank you.
මම අරක upload කරන්න rheumatology එක upload කරන්න දැන්. So do that and tomorrow also I think same time should be fine for me, I think.
Okay, sir. No problem. Thank you, sir.
Right. Okay, right. I'll see you tomorrow then.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Sir.
Thank you, sir.
Okay, right.